Welcome back, everyone. Today we'll discuss about endocrinology. The first most important thing is diabetes. I'll tell you what and how a question is framed in endocrinology and what are all the things you'll have to remember. Some topics may be out of PLAB, but please do remember that the concept is really important to crack a clinical case. All right. We all know what's hypothalamic pituitary axis and everything else. First, most important topic is diabetes. Diabetes is basically of two types, that is of type 1 diabetes and type 2 diabetes. Type 1 diabetes is also called as insulin deficiency, and type 2 is basically insulin resistance. When I say insulin resistance, for your real life exam, you will have to make sure that obesity, family history, and polycystic ovarian disease and gestational diabetes all falls in insulin resistance. So whenever there is an option of whenever there is a word mentioning that the BMI is more than 30 or patient has got obesity or patient has got a family history of diabetes or patient has got polycystic ovarian syndrome or gestational diabetes, it is insulin resistance. Most classically and recently asked questions include lack of physical activity. Whenever there is lack of physical activity, it is also related to insulin resistance. So insulin resistance usually causes type 2 diabetes mellitus. Coming back to type 1 diabetes status, it is basically because of the autoimmune beta cell destruction. Whenever I say autoimmune beta cell destruction, the examiner must have to tell you that there is another autoimmune disorder associated with this condition, which can be given as an indirect clue. Most commonly, the examiner will tell you that this patient might be having autoimmune hypothyroidism, or the examiner can tell you that there can be atopic dermatitis, or the examiner can tell you the patient has got celiac problem, or the examiner can tell you adrenal problem is an association. So whenever there is an autoimmune association, it is type 1 diabetes until otherwise proved. All right. What is the first most important thing you'll have to remember for type 1 diabetes mellitus and type 2 diabetes mellitus? Type 1 diabetes mellitus is usually prone for ketoacidosis. Diabetic ketoacidosis is commonly seen in type 1, whereas hyperosmolar hyperglycemic coma is usually associated with type 2. Coming back to other types, it is latent autoimmune diabetes in young. How do I remember or how do I diagnose a latent autoimmune diabetes in adults? It is very easy. The name itself indicates that it is adults, it is not elderly. So the patient is a young to middle aged patient associated with any of the autoimmune conditions. Now you understood what an autoimmune condition or what clues can be given to for you to think as an autoimmune condition. Atopic dermatitis, Addison's disease, hypothyroidism, celiac disease, these are all the autoimmune disorders that are given for PLAB1 examination. All right. Gestational diabetes is nothing but it happens during pregnancy. Talking about the diagnostic criteria, whenever you think that the HbA1c is more than 48 millimole per moles, it is usually diabetes mellitus. Fasting plasma glucose, if it is more than 7, it is diabetes mellitus, and random plasma glucose of more than 1.1 along with the symptoms. What are the symptoms? Can be polyuria, can be weight loss. These are the things that is usually given for PLAB examination. This is a diagnostic criteria and examiner would like to test you on this because most of the times the examiner gives you symptoms with the random plasma glucose in the question. If the fasting plasma glucose is 10, even with or without symptoms, the patient has got diabetes mellitus. That's it. All right. Other one most important thing, the examiner can tell you that the patient has got a pre-diabetes. How do you develop pre-diabetes? The patient is at risk of developing obesity, or the patient is at risk of not working out or not exercising. That is when you will have to diagnose pre-diabetes, given that the values are in place. That is, impaired fasting glucose must be 5.6 to 6.9. Impaired glucose tolerance test in 2-hour load is 7.8 to 11. And non-diabetic hyperglycemia is HbA1c of 42 to 47. Remember, if HbA1c is more than 48, it is diabetes. If it is less than 48, and more than 42, it is pre-diabetes. This is what I want you to understand. All right. Based on this combinations and permutations, the examiner can ask you any of the things. All right. Did you see that the patient has got random glucose of 11.1, more than 11.1, along with symptoms? And the symptoms are polyuria, polydipsia, weight loss, and ketosis. This usually suggests type 1 diabetes mellitus. All right. Next, we talk about the treatment. When you see the treatment, the basically the type 1 diabetes is because of the insulin deficiency, given that the patient has got autoimmune beta cell destruction. Whereas for type 2 diabetes, it is because of the obesity or patient who has got polycystic ovarian syndrome, gestational diabetes, or not working out, less physical activity. It is basically insulin resistance. So the treatment aims at correcting the molecular mechanism, that is insulin deficiency in type 1 and insulin resistance in type 2. Insulin therapy in type 1 is the treatment. Metformin is the first line treatment for type 2. All right, this is very clear. But the examiner will tell you and confuse you, saying that type 2 diabetes mellitus patient has been using metformin, now presenting with tiredness, now presenting with confusion, now presenting with metabolic acidosis. What do you think of? It is not hypoglycemia, because metformin does not cause hypoglycemia. This is what you will have to remember for PLAB1, please. Metformin does not cause hypoglycemia. It is the metformin induced metabolic acidosis, metformin induced other problems which are not important for your level. But please do remember, metformin does not cause hypoglycemia. Talking about the management of diabetes mellitus, it is usually very easy. We've already discussed type 1 diabetes, it is insulin supplementation. Type 2 diabetes, it is metformin. But before starting the medications, and if patients wants to understand that, sorry, if the examiner wants to test you before giving the medications, what do you do? It is the diet, exercise, and weight control. Yesterday, we talked about diet as a lecture. In cardiovascular medicine, it is good fruits that you will have to eat, plenty of fruits which can provide cardiovascular health. What do you have to do in diabetes mellitus? Cut down carbohydrates. Even if the patient is not able to cut down carbohydrates, balanced diet is one thing you will have to make sure. Patient must exercise, and weight control is one most important thing. After you do the diabetes management or start diabetes management, the examiner can ask you HbA1c needs to be measured often. How often do you measure HbA1c? It is every 3 months you will have to do. Forget about 3 to 6 months, but it is every 3 months that you will have to do, please. All right. Next, we talk about some of the management conditions, sorry, some of the medical management of type 2 diabetes mellitus. I will have to tell you metformin plus lifestyle is the first line therapy. If there is a second step that you will need to add, you add a SGLT2 inhibitor or a DPP4 inhibitor. SGLT2 inhibitor is empagliflozin, that is usually cardioprotective and renoprotective. It usually causes excretion of glucose by urine. Whenever there is excretion of glucose by urine, the urine acts as a culture medium for the bacteria to grow, because the glucose is excreted in the urine. This urine acts as a medium for the bacterial culture, so there will be recurrent urinary tract infections who are on SGLT2 inhibitors or empagliflozin. Talking about the DPP4 inhibitors, it is the sitagliptin. It has no effect on weight. Please do remember this. This is very important for PLAB, even if it is not given on any other medication or any other websites or any other study guides. All right. If the HbA1c is still more than 6.5, you will have to add insulin even after all these medications, please. Very important. All right. Triple therapy is with sulfonylurea, thiazolidinone, and then you can go to insulin if HbA1c remains high, that is more than 6.5. All right. Next, we talk about some of the oral hypoglycemic agents. Metformin causes insulin sensitivity. The GI upset and lactic acidosis are the most common side effects. SGLT2 inhibitors usually causes urinary tract infection. DPP4 is a weight neutral. The sulfonylureas can cause hypoglycemia. Thiazolidinones can cause fluid retention, which can increase the cardiovascular strain. That is why thiazolidinones are contraindicated in heart failure. All right. Next, we talk about some of the complications that we will have to. Insulin therapy is not really important for you. It is for MRCP. Diabetes complications we will have to understand. Commonly, I would like to tell that students who are preparing for PLAB1, two most important complications. It is diabetic ketoacidosis is one complication commonly seen in type 1. Hyperglycemic, hy- hyperglycemic hyperosmolar state is another complication that is commonly seen in type 2. Talking about diabetic ketoacidosis, diabetic is nothing but increased blood sugar. Keto is increased ketones. Acidosis is pH is less than 7. Remember that in ketoacidosis, ketones are positive on urine. This is called diabetic ketoacidosis. So, whenever you want to diagnose diabetic ketoacidosis in exam, you will have to remember that ketones must be present along with raised glucose and acidosis, which is common in type 1. All right. How do you treat is the question. It is give IV fluids. IV fluid 0.9% normal saline, and then you can give insulin infusion with dextrose and also potassium's monitoring or potassium supplementation. Very important because insulin causes driving of potassium into the cells, which can cause hypokalemia. That is why you give insulin infusion. Next, we talk about hyperosmolar hyperglycemic state. It is usually seen in type 2 diabetes mellitus. Hyperosmolar osmolarity is high with the increased glucose, and there will not be any ketoacidosis. It is only the hyperglycemic state, it is only hyperosmolar state, but there is no ketoacidosis. I'm repeating this multiple times because you will get a question on these complications in PLAB1 exam. The treatment again for hyperosmolar hyperglycemic state is giving normal saline. How much of normal saline? It is usually 0.9% normal saline. And if there are any other complications or if there are any other electrolyte corrections that you need, you will have to do the electrolyte abnormalities correction. All right. Talking about the diabetes microvascular and macrovascular complications, I will have to tell you that any patient who has got diabetes for more than 5 years, they need renal screening and retinal screening. Remember, in the clinical practice, what we usually do is if the patient has got urine dip positive or if the patient has got diabetic nephropathy that is positive, it indicates that the patient is also at a risk for developing diabetic retinopathy. That is why we screen diabetic nephropathy and diabetic retinopathy at the same time. Whenever there is diabetic nephropathy, it usually causes proteinuria, microalbuminuria, so you will have to make sure that the patient has got normal kidneys. That is why you will have to check for diabetic nephropathy. And the examiner can ask you what is the most sensitive thing you can do. It is the albumin creatinine ratio that you will have to check for diabetic nephropathy. Next, we talk about diabetic, it is the albumin creatinine ratio. If urinary albumin creatinine ratio is more than 30 milligrams per millimole, it indicates that the patient has got diabetic kidney nephropathy. Next, we talk about diabetic retinopathy. It is usually the microvascular changes that are involved. Whenever there is microvascular changes that are involved, it is the eye disease and the renal disease that are affected. So you will have to mandatorily screen for eye problems in diabetic patients every year. Whenever there is diabetic retinopathy, the examiner can tell you that the patient has got microaneurysms or hemorrhages or hard exudates or cotton wool spots, or there can be neovascularization. Neovascularization is nothing but the new vessel formation. Whenever there is a new vessel formation, it indicates that there is proliferation going on. So, proliferative diabetic retinopathy is present when neovascularization is seen. All right. Cotton wool spots, if it is present, it indicates it is pre-proliferative diabetic retinopathy. How do you control diabetic retinopathy? It is good glycemic control, control of HbA1c, control of blood pressure, and you can also do pan-retinal photocoagulation. Recently, bevacizumab is one medication that has been approved by the NHS to treat diabetic retinopathy. Talking about bevacizumab, what is it? It is a monoclonal antibody that acts against VEGF, vascular endothelial growth factor, which can disrupt the neovascularization and can prevent diabetic retinopathy. There can also be other complications such as diabetic foot ulcers, or patient can develop insulin injection site complications as well. Commonly, diabetic neuropathy and diabetic foot ulcers are usually asked. Whenever there is diabetic neuropathy, glow and stalking neuropathy is the most commonly asked question in PLAB1. The examiner can tell you that the patient feels like he is walking on a cotton ground, or there can be burning, numbness, and tingling sensation as well. There can be tight glycemic control and prevention of foot trauma that is usually asked or usually given in the options for diabetic neuropathy, please. But the most important thing, you'll have to remember that it is the burning, numbness, and tingling sensation in the extremities that the examiner is usually asking. Talking about the control of blood pressure in diabetes, sorry, we will also talk about some of the diabetic foot ulcer management. Whenever there is diabetic foot ulcer, it is usually glycemic control and blood pressure control. Sometimes the examiner can also give you in the question saying that the patient is a heavy smoker. What do? You will have to make sure that smoking cessation must be done in patients who is got diabetic foot ulcer. Sometimes the examiner can directly give an option of refer to podiatry. Please do refer to podiatry or diabetic foot team if there is a diabetic foot ulcer. All right. Next, we talk about controlling blood pressure in diabetes mellitus. Yesterday, we discussed whenever there is blood diabetes mellitus, what is the antihypertensive of choice? It is the ACE inhibitor. If ACE inhibitor patients develop cough, it is ARBs that we usually do. So the first line is ACE inhibitors, and the contraindications are they are contraindicated in pregnancy. Diabetic foot, we just discussed, not needed. Diabetic foot ulcers, diabetic neuropathy, we have discussed. But remember, in patients who have got diabetes for more than 5 years or with the poor control of diabetes, and now the patient complains of dizziness or falls with the postural drop of systolic blood pressure more than 20, what is the next best step? Is the first question the examiner can ask you. You will have to go select the option of fludrocortisone, or if fludrocortisone is not there, midodrine needs to be given as the most important thing. All right. Next, we talk about special situations for you. Okay, we'll talk about special situations usually not asked, but we can discuss about gestational diabetes in gynecology and obstetrics. Next, we talk about hypoglycemia. If the blood sugar is less than 3.9, it is hypoglycemia. Commonest endocrine emergency as well. What do? Just give him glucogel, or if the patient has got hypoglycemia of less than 2, give him glucagon injection. That is very important, please. All right. Next, we talk about insulinoma. Insulinoma is basically they will ask you, they will tell you that the patient has got recurrent hypoglycemia. Then you will have to think of insulinoma. It is usually a Whipple's triad that we usually consider. Give me a minute, please. I'll show you what insulinoma. Yeah, insulinoma classic presentation is Whipple's triad. Whipple's triad is usually symptoms of hypoglycemia during fasting or exercise, and you must have a documented low blood pressure during the symptoms, and the symptoms are relieved with administration of glucose. All right. Next, we talk about one of the most important complications of diabetes. It is diabetic ketoacidosis. Whenever there is diabetic ketoacidosis, I want you to look for the cause. What is the cause of diabetic ketoacidosis? It is polyuria, what is the cause? It is the dehydration. It is the infection that usually exacerbates or presents as diabetic ketoacidosis. So please do treat for infection and dehydration as well. The examiner can give you the clinical findings of polyuria, polydipsia, dehydration, sometimes sweet smelling breath as well. The examiner can tell you that the patient has been prolongedly fasting or patient is missing insulin doses as well. This is one trigger for development of diabetic ketoacidosis. How do you diagnose diabetic ketoacidosis on clinical examination? It is the dehydration signs. Very important, please. Patients with the diabetes and with the dehydration signs, you will have to think of the increased risk of diabetic ketoacidosis. So, dehydration signs are dry mucous membrane, hypotension, that is the low blood pressure, and tachycardia with increased heart rate. The precipitating causes usually infections, starvation, missed insulin doses, and patient is usually taking concurrent medications as well. PLAB1 exam, classic question. The patient mentions that the examiner mentions that the patient has been night out in a party, not taken any insulin, and then he presented to the A&D early morning. That is one you will have to think of diabetic ketoacidosis. Next, we talk about investigations in diabetic ketoacidosis. There will be increased blood sugar, positive ketones, and ABG shows metabolic acidosis. What is the treatment? Again, it is 0.9% normal saline with IV infusion with 5% glucose, and there will be hypokalemia because of the insulin treatment. So, you will have to make sure that you give insulin as well or potassium supplement as well. If you're not treating diabetic ketoacidosis, or say for example, if the examiner told you that the patient has been having diabetic ketoacidosis for so long, what could be the problem? If the patient is not improving, then you will have to think of complications that is usually asked. What are the complications? It is the cerebral edema, it is cardiac arrhythmia because the patient can be having hypokalemia and can develop cardiac arrhythmias, or patient can develop pulmonary edema as well. Most importantly, it is on examination. The examiner can tell you that the patient has got fruity breath on examination. This is one thing you will have to remember. All right. This is what diabetes mellitus is about. All right. We'll take 2 minutes break and then we will start our discussion with the thyroids. Thank you very much. Whenever you see regarding thyroid, first most important thing, whenever you think of thyroid disorder, which is the first line test? It is the TSH that needs to be done, please. All right, TSH needs to be done as an important investigation for checking thyroid disorders. If TSH is high and T4 or T3 is low, it is primary hypothyroidism. If TSH is high and T4 or T3 is normal, it is subclinical hypothyroidism. If TSH is low and T4 is high, it is primary hyperthyroidism. If TSH is low and T3 or T4 is normal, it is subclinical hyperthyroidism. If TSH is low or normal with the T4 and T3 being low, it is the central pituitary hypothyroidism that is usually given for PLAB1 exam. This is very important slide. If anyone wants to take a picture, you'll have to take this. This is very important and you will expect a question for PLAB1. All right. First, most important thing, what is the underlying clue for the diagnosis of thyroid disorder? The examiner will classically tell you that the patient has got atrial fibrillation. Please do check for thyroid disorder. And another important thing, whenever there is history of depression or anxiety, what is the first endocrine hormone you check? It is again the thyroid disorder, please. All right. Next, we talk about some of the antibodies. It is anti-TPO and anti-thyroglobulin antibodies. We check for autoimmune thyroiditis. If it is a diagnosis of Graves, you will have to check for TSH receptor antibodies. Next, we talk about hyperthyroidism signs and symptoms. Please do remember in hyperthyroidism, there can be increased appetite, there can be weight loss as well. Given that the patient has got palpitations and atrial fibrillation, that is the reason we check thyroid as the most important endocrine hormone. Given that the thyroid usually controls every cell, the basal metabolic rate, it is usually the metabolic rate of every cell is controlled by thyroid. That is why we usually make sure that the basal metabolic rate in normal persons are normal. If the basal metabolic rate is affected, there is a problem with the thyroid. If thyroid hormone level increases, the basal metabolic rate increases. That is why the patients usually develop diarrhea. And in females, it is oligomenorrhea and fatigue and labile emotions that usually presents as a feature of hyperthyroidism. If you are examining the patient, you will find that there is tremor, you will find that there is increased sweating, there will be brisk reflexes, there will be lid lag, and there will be palmar erythema. Remember, the most important physiology behind this is again increased metabolic rate, please. There's no much great God medicine. It is just the increasing metabolic rate that happens in hyperthyroidism. That is by function of every organ, every cell increases, which usually appears as a side effect. Increased appetite, heat intolerance, sweating, tremors, irritability, palpitations, racing of heart, diarrhea, oligomenorrhea, labile emotions as well. All right. Next, we talk about hypothyroidism diagnosis and causes. Graves' disease is one most important thing. Most of the patients with hyperthyroidism, Graves' disease is the most important cause. Toxic multinodular goiter is one most important cause in elderly. Toxic adenoma is a single hot adenoma. Thyroiditis, it is decurvains, it is painful, it is transient hyperthyroidism. Very important, only thyroid abnormality which is painful is decurvains thyroiditis. That's it. Chapter closed. No, need not think anything. If it is painful, it is decurvains thyroiditis, usually followed by viral infections. All right. There can be antimicrosomal antibodies that are positive in Graves' disease as well, please. All right. Next, some of the causes of hyperthyroidism where the examiner can frame a question saying that the patient is a nursing student and the patient is a normal patient whose mother or father has got a thyroid, that indicates that exogenous thyroid injection she is taking with hyperthyroidism being the manifestation. All right. When we talk about the treatment of hyperthyroidism, it is symptomatic control with the beta blocker. If the symptoms are controlled, then you can do anti-thyroid drugs such as carbimazole. The examiner would love to ask you what is the side effect of carbimazole. It is bone marrow suppression, it is agranulocytosis, it is cutis aplasia when used in pregnancy. The side effect of propyl thiouracil is liver failure. Sometimes the examiner wants you to understand thyroidectomy or radioiodine therapy can also be used for the treatment of hyperthyroidism. Next, we talk about thyroid eye disorders. It is Graves' ophthalmology. Please do remember whenever the examiner mentions eyelid retraction, exophthalmos, hyperthyroidism, it is thyroid eye disorders or Graves' disease. What is the first most important thing? You will have to make high dose steroids needs to be given for thyroid eye disease or Graves' ophthalmology. Next, we talk about goiter and Graves systemic manifestations. Again, goiter and Graves for PLAB1, it is the hyperthyroidism features that you will have to remember. Next, we talk about hypothyroidism. Whenever there is hypothyroidism, you will have to tell me what hypothyroidism is. It is the decreased basal metabolic rate that is usually happening. So, the patient presents with the reverse symptoms of hyperthyroidism. It is nothing but tiredness, lethargy, cold intolerance, weight gain, constipation, hoarse voice, poor memory, depression, myalgia, cramps, menorrhagia. Patient's heart rate becomes slow because the basal metabolic rate of the heart decreases. bradycardia happens. There will be dry skin, thin skin, puffy face. All these will be happening in hypothyroidism. When we talk about the causes of hypothyroidism, first most important thing is primary hypothyroidism, which we have already seen that there can be increase in the TSH and there can be decrease in the functional T4. If it is a secondary hypothyroidism, there will be decrease in TSH and there can be decrease in T4 as well. All right. Whenever there is hypothyroidism, what did we discuss in diabetes? It is a underlying clue for the development of autoimmune disorder or the presence of an underlying disorder. If it is a hypothyroidism patient, the patients are usually associated with autoimmune conditions and type 1 diabetes mellitus, please. All right. Iodine deficiency is another cause that can cause hypothyroidism. That is why we use iodinized salt, which can prevent hypothyroidism. Pink salt does not contain iodine. Patients who take pink salt are more prone to hypothyroidism. One most important thing. In children, it is congenital hypothyroidism that you will have to remember as a cause for hypothyroidism. I will tell you one most important scenario where the examiner can ask you. Pediatric patient presenting with swelling in the neck and was diagnosed to have a thyroglossal cyst. The thyroglossal cyst has been removed, and now after a few months the patient presents with the tiredness, lethargy, fatigue. What is the diagnosis? It is the hypothyroidism. Why? Because thyroglossal cyst usually contains thyroid gland. So, without checking or without doing an ultrasound or without confirming that there is an additional thyroid tissue, if you take out the thyroglossal cyst or thyroglossal duct, the remnant of the thyroid is lost, isn't it? That is why patients can develop permanent hypothyroidism in whom they have undergone thyroglossal duct or thyroglossal cyst surgery. One most important thing, I know this might not be asked in PLAB, but for pediatric patients, this is one of the most important causes of iatrogenic permanent hypothyroidism, please. So, very good potential for the examiner to ask in PLAB1. Next, we talk about the treatment of hypothyroidism. I would like to tell you that it is thyroxine supplementation or T4 supplementation that we usually do. Next, we talk about a rare case of hypothyroidism. It is myxedema coma. It is a life-threatening complication of severe untreated hypothyroidism. That is why it is important to treat hypothyroidism, please. All right. You do not have subclinical hypothyroidism. That should be all right. But I will talk about some of the thyroid disorders in special population as well. Thyroid disorders in pregnancy is what we will have to think of. Whenever there is thyroid disorder in pregnancy, it can cause hyperthyroidism. And first most important thing is propyl thiouracil we will have to use. If we use propyl thiouracil in pregnancy, the side effect can be hepatic derangements or hepatic abnormalities. If we use carbimazole, it is cutis aplasia. Whereas for the treatment of hyperthyroidism in pregnancy, it is the second and third trimester and post pregnancy. You can use carbimazole or you can also do partial thyroidectomy, please. All right. Next, we talk about hyperthyroid crisis. Whenever there is hyperthyroid crisis, obviously it's a manifestation of hyperthyroidism, which is very severe. So we will have to make sure that palpitations needs to be treated by beta blockers, and then you will have to find out what could be the cause of the trigger for the thyroid crisis. Could it be dehydration? Could it be infection? Could there be starvation or any other things? This is what you'll have to think of. If it is an infective etiology, you will have to treat this patient with IV antibiotics. All right. Next, we talk about some of the most important question that is being asked. What is it? It is patient mentioning that the patient has been recently delivered a child and the patient is delivered a child 6 months before. Now the patient presents with some of the symptoms which are suggestive of postpartum thyroiditis. What is the best thing you will have to do? Do not do anything is my question. But if you notice that the patient has got symptoms and symptoms needs to be controlled, it is the beta blocker that needs to be addressed, please. All right. Next, we talk about hyperparathyroidism. Remember, primary hyperparathyroidism is commonly asked question in PLAB1. I would like to tell you that whenever there is parathyroid hormone, even if it is borderlinely raised, it is to be considered a cause of hypercalcemia. The first most important cause of hypercalcemia is primary hyperparathyroidism. Talking about primary hyperthyroidism, the causes for primary hyperparathyroidism, it is the solitary adenoma that we usually think of. Most of the times, if there is no solitary adenoma on ultrasound, it is hyperplasia of all the four glands that we will have to think of, please. How do you diagnose the patient? It is with the raised serum calcium with inappropriately high or normal PTH. This is what you will have to remember, please, for PLAB1. I know most of the students do not worry about all these things, but the normal PTH is usually a common question that's been asked or that's been told in the exam. If it is a normal PTH, most of the patients, most of the students do rule out primary hyperthyroidism. But I want you to understand, even if the patient has got hypercalcemia with normal PTH, please do think of primary hyperparathyroidism as one of the most important causes. Talking about the symptoms, obviously it is the hypercalcemia symptoms, which you all know that there can be renal stones, abdominal moans, and psychic moans as well. If it is a bone disease, it is usually absorption of the calcium from the bone that causes osteoporosis, fractures, and if the osteoporosis is much more higher, going on a higher rate, it usually causes fibrosis and cysts around that area that results in osteitis fibrosa cystica. Parathyroid hormone is phosphate thrashing hormone. It is nothing but the phosphate is gone throughout through the urine outside. So whenever there is primary hyperparathyroidism with the raised PTH or normal PTH, there will be increased serum calcium and low serum phosphate with increased ALP. When I talk about ALP, I remember one famous question, Paget's disease, where there will be calcium normal, phosphate normal, everything is normal, but ALP is the only thing that is increased in Paget's disease. That is how you diagnose Paget's disease. Talking about the management of primary hyperparathyroidism, if the primary hyperthyroidism is diagnosed, you will have to make sure that a parathyroidectomy needs to be done. All right. If there is medical management, Sinacalcet is one important medication you will have to use for primary hyperparathyroidism. Again, this might not be given in any of the banks. You will have to remember this. Sinacalcet is very important. All my juniors, my F1, F2 knows about Sinacalcet. So you will have to know this. This can be asked in the question, please. All right. Next, we talk about secondary and tertiary hyperparathyroidism. Secondary hyperparathyroidism indicates that the cause is secondary, not in the primary part. That is, primary part is parathyroid gland. So the problem is somewhere. It is usually the chronic kidney disease. It causes decreased calcium and increased parathyroid hormone. All right. Tertiary hyperparathyroidism, there will be increased calcium and increased parathyroid hormone as well. Secondary hyperparathyroidism, usually the chronic kidney disease, whenever the patients have got chronic kidney disease, there can be parathyroid hyperplasia because of the hypocalcemia that's been going on for a long time. So the lab abnormalities usually we see are low calcium, increased parathyroid hormone, and increased phosphate in patients who have got chronic kidney disease, because the kidneys are all damaged. So even when the parathyroid hormone is increased, the phosphate thrashing is not gone. Phosphate is not excreted. That is why patients do have increased phosphate in chronic kidney disease. Next, the treatment for secondary hyperparathyroidism, when we talk, it is the treatment with or correction of hypocalcemia. How do you correct hypocalcemia? You either give vitamin D or you supplement calcium or you supplement both. There is no harm. Vitamin D with the calcium is the treatment for secondary hyperparathyroidism. Next, we talk about tertiary hyperparathyroidism, where there will be production of parathyroid hormone following a CKD patients after a long time. That is why tertiary hyperthyroidism usually presents after secondary hyperparathyroidism, because there will be the autonomous production of parathyroid hormone. All right. So there can be increased calcium and increased parathyroid hormone as well. The glands become hyperplastic and adenomatous. Whenever the glands become hyperplastic and adenomatous, what is the treatment? You'll have to remove that hyperplastic glands or adenomatous glands. So you will have to do surgery. Surgery is the definitive treatment for tertiary hyperparathyroidism. I want you to understand cinacalcet is also used in the treatment of hyperparathyroidism. Malignancy associated hypercalcemia. This is in PLAB1. Please do remember that the lung cancer squamous cell carcinoma usually causes parathyroid hormone related peptide, which can cause hypercalcemia. All right. Next, we talk about Cushing syndrome. We'll take a break for 2 minutes and then we'll come back and talk about Cushing syndrome. Thank you very much. Welcome back, everyone. Now we'll talk about Cushing syndrome. When you talk about Cushing syndrome, syndrome is basically constellation of signs and symptoms. All right. In Cushing syndrome, there will be increased glucocorticoid exposure for a prolonged period of time. That is why there are multiple signs and symptoms that has been developed, which is termed as Cushing syndrome. Usually, what happens is there are two types of Cushing syndrome. One is ACTH dependent, and another one is ACTH independent. ACTH dependent is usually Cushing's disease, that is, the ACTH is produced from the pituitary, whereas ACTH independent is adrenal adenoma. And in adrenal adenoma, there will be lot of cortisol that is being produced. ACTH independent tumor, ACTH dependent tumors can also be caused by the ectopic ACTH production, such as small cell lung cancer and carcinoid tumors. Sometimes the patient can also take exogenous ACTH, that is when they call it as ACTH dependent. Talking about ACTH independent, it is adrenal adenoma or adrenal carcinoma, or sometimes there can be adrenal nodular hyperplasia. Again, if it is ACTH independent, there can be exogenous glucocorticoid administration as well, please. That is one thing you will have to remember. Talking about Cushing syndrome, signs and symptoms, the most important symptom the examiner can tell you is irritability and weight gain. There can be buffalo hump neck, that is fat pads in the neck. There can be moon faces as well. The patient can develop hypertension. The patient can develop easy bruisability. The patient can develop osteoporosis. Most classically, there will be obesity with the purple striae, with the peripheral muscle wasting. These are all the things that can be seen. In women, it is the hirsutism that is characteristic in Cushing syndrome. What do you have to do for investigations? If you want to do the investigation, the first line is overnight dexamethasone suppression test. If you want to confirm, you will have to confirm that 24-hour urinary free cortisol is elevated. Very important, please. Overnight dexamethasone suppression test, that is the first line test. And then if you want to confirm, it is 24-hour urinary free cortisol that you will have to consider, and it is elevated. If you want to identify the cause or localize the source, what do? You will have to do a plasma ACTH level. If it is high, it is indicative of ACTH dependent. If plasma ACTH is low, it indicates that it is ACTH independent. All right. If you are not able to differentiate that the high ACTH, is it because of the pituitary production, or if the patient is taking from exogenous source, you will have to then do a high dose dexamethasone test. Please do remember this. This is very classic and very commonly asked. If ACTH is high, you will have to make sure that you do a differentiation test. And how do you differentiate, and what are you differentiating it from? You are differentiating it between a pituitary cause and an ectopic cause. High dose dexamethasone test versus MRI pituitary needs to be done. If ACTH is low, you can just do a CT or an MR scan of the abdomen to find out if there is any adrenal tumor that is producing the cortisol. All right. What are the treatments that we use for Cushing syndrome? First, most important thing is if the patient is taking exogenous steroids, you will have to withdraw the steroids. Very useful. If the patient has got a pituitary adenoma, it is a transsphenoidal adenoma that is usually seen. If the patient has got an adrenal tumor, it is adrenalectomy. If the patient is having an ectopic ACTH production or excessive ectopic ACTH production, you will have to consider for the treatment of the other tumors as well. Talking about the drug therapy, the most important medications which are used to control the cortisol synthesis is metirapone, ketoconazole, or osilodrostat. Very important new medication. You do not know about this medication, but please do remember this: metirapone, ketoconazole, and osilodrostat is the most important thing. What is Nelson syndrome? Examiner can ask you about Nelson syndrome, please. After you do a bilateral adrenalectomy, the pituitary glands start producing more and more ACTH just to give you an impulse saying that please do produce cortisol. But what happens in post bilateral adrenalectomy? There are no adrenals, and the pituitary gland starts on sending so much of ACTH. This ACTH has got pigmentation capability, so the patient becomes hyperpigmented. This is called as Nelson's syndrome, please. Very important. Most of the students do not know, but I want you to know about this. Next, we talk about adrenal insufficiency. My go-to adrenal insufficiency is if the patient in the question has got hypothyroidism, celiac disease, adrenal insufficiency must be ruled out because it is autoimmune. 80% of the causes for adrenal disease is autoimmune. That is why look for celiac disease, look for hypothyroidism, look for type 1 diabetes mellitus, look for atopic dermatitis. This is one important thing you will have to rule out if there is any autoimmune disorders. Next most important thing is if there is any problem with the pituitary or the hypothalamic problem, or if the patient body is not able to produce ACTH, it is called as adrenal insufficiency, especially it is secondary adrenal insufficiency. If you want me to list out the causes for primary Addison's disease or primary adrenal insufficiency and secondary adrenal insufficiency, I would like to tell you that autoimmune causes are one most important thing. Infections and hemorrhage can be the second most important thing for adrenal insufficiency. There can be congenital adrenal hyperplasia and drugs such as ketoconazole that can cause adrenal insufficiency. But I'll tell you what are all the things that are important for PLAB1. For PLAB1, it is the autoimmune cause that is the first most important thing. Second most important thing is tuberculosis that can cause adrenal insufficiency. Sometimes the patient can have meningococcal fever and then the patient can present with adrenal hemorrhage. Patient can present with metastasis to adrenals as well. All right. Whereas the second line adrenal insufficiency is basically because of hypothalamic and pituitary deficiency, which can cause decrease in the ACTH production. There can be long-term steroid use the patient is taking and there is decreased ACTH. That is why the patient can be also having adrenal insufficiency. This is one thing you will have to remember. Talking about Addison's disease symptoms, my first go-to symptoms are weight loss, loss of appetite, and postural hypotension with nausea, vomiting. These are the things I will have to remember for Addison's disease, please. Very, very, very important, please. If you do not understand one of the endocrine problem and still want to choose an endocrine option, it is Addison's disease until otherwise proven, please. It can cause any other problems, but the most important thing for your exam is nausea, vomiting, loss of weight, and loss of appetite with postural hypotension is Addison's disease. If you want to diagnose Addison's disease, it is the patient will be having hyponatremia, hyperkalemia, and hypoglycemia. These are the three most important positive findings. If you do an early morning cortisol, obviously it will be low. If you do an ACTH in primary and secondary adrenal insufficiency, it will be high. Sorry, in primary, it will be high, and in secondary adrenal insufficiency, it will be low. If you do a ACTH stimulation test, cortisol will not be increased in Addison's disease, especially in primary Addison's disease. All right. Next, we talk about the treatment. Remember, guys, for PLAB1, if you have got postural hypotension. It is fludrocortisone that is the treatment until otherwise proven. That's it. But for Addison's disease, it is the glucocorticoid replacement, such as hydrocortisone or glucocorticoids, and then fludrocortisone or mineralocorticoids that needs to be given, please. All right. Next, we talk about you don't need this, and then we talk about hyperaldosteronism. Whenever there is hyperaldosteronism, there will be increase in the aldosterone production. The most common cause of secondary hypertension. The examiner can usually tell you that the patient has got blood pressure that is increased and is not being able to be responding to two or three antihypertensive medications. This is one thing you'll have to remember. Another thing is secondary hyperaldosteronism, which is usually by the excess aldosterone driven by high renin levels. All right. Primary hyperaldosteronism, also called as Conn syndrome for PLAB1, it is usually because of the adrenal adenoma or adrenal hyperplasia or adrenal carcinoma. Sometimes there can also be secondary hyperaldosteronism where there can be renin production tumor or there can be renal artery stenosis. Please do remember that patients with hypertension and flash pulmonary edema is a diagnosis of renal artery stenosis until otherwise proven. Talking about hyperaldosteronism, whenever there is hyperaldosteronism, the clinical features are very important. It is because most of the symptoms are due to hypokalemia. Whenever there is no potassium in your body, you feel weak, you feel having cramps, you feel paresthesia, polyuria, and diplopia. Hypertension, polydipsia, sorry, not diplopia. Hypertension is obviously common, but hypokalemia is not always common. Very important thing. So, in the question, you will have to look for hypertension, hypokalemia, and metabolic alkalosis. Whenever there is a low potassium in the body, it is usually associated with metabolic alkalosis. Next, we talk about the investigations that are needed for primary hyperaldosteronism. How do you diagnose hyperaldosteronism? It is usually the renin levels and aldosterone levels. The examiner can give you that the patient has got plasma renin and aldosterone ratio that can be used for screening. For confirmation, you will have to do a saline infusion test, but do not worry about that. The treatment is laparoscopic adrenalectomy to make sure that you do the remove the adenoma, or if you want to go for medical treatment, it is the aldosterone antagonist that is usually spironolactone. The complications of spironolactone are gynecomastia, and examiner wants you to choose another medication. It is eplerenone, please. All right. Next, we talk about secondary hyperaldosteronism, Bartter syndrome. That should be all right. Don't worry. We'll discuss in the renal things. And next, we talk about hirsutism. One most important thing is polycystic ovarian syndrome, is what I want you to rule out if there is hirsutism, please. All right. Next, we talk about virilism, gynecomastia, and erectile dysfunction. If you are thinking of virilism, please do remember that androgen secreting tumor needs to be ruled out. If it is gynecomastia, please do make sure that estrogen and androgen ratio are increased in gynecomastia. erectile dysfunction, the examiner will tell you that the patient has got lot of stress, anxiety, depression. Please do remember that psychogenic causes of erectile dysfunction are most important. And how do you treat it? You treat it by counseling, please. That is why counseling is first given. Next, PDE5 inhibitors such as sildenafil or vacuum devices can also be used. All right. I don't think you need this one. Next, we talk about hypopituitarism. Very important. Remember, for you to diagnose hypopituitarism, I will tell you some of the important clues that can be asked for PLAB1 or given for PLAB1. It is usually the malnutrition, starvation, sudden weight loss, surgery, trauma to the head causes hypopituitarism. That's it. These are the most important findings that you will have to look for in hypopituitarism. Everything is decreased, so patients' function, mobility, basal metabolic rate, everything is decreased as well. All right. How do you diagnose? All the hormones are decreased. That's it. Nothing much, nothing great medicine is here. How do you treat it? First, most important thing, you will have to make sure that steroids must be given, hydrocortisone must be given, levothyroxine must be given, sex hormones needs to be supplemented, growth hormones needs to be given, and fertility needs to be treated as well. Very importantly, it is the hydrocortisone that is the first medication that needs to be given, please. All right. Next, we talk about pituitary tumors. I'll talk about only some of the important pituitary tumors. Hyperprolactinemia, there will be increased prolactin. Obviously, this leads to low LH and FSH and causes hypogonadism. Antipsychotics, metoclopramide can cause hyperprolactinemia. But if there is a pituitary mass, it is usually causing bitemporal hemianopia is one thing. If you are thinking of clinical presentation, women presents with menstrual disturbances such as amenorrhea, and men presents with erectile dysfunction as well. The other causes of hyperprolactinemia could be hypothyroidism or any brain injuries as well. All right. Bitemporal hemianopia is one most important presentation. Next, we talk about the management of hyperprolactinemia. If there is management of hyperprolactinemia that is usually asked, you will have to first send the investigations to confirm if there is any increased serum prolactin level. Please do check for serum prolactin level. Serum prolactin is increased. Pituitary MRI, if you do, there is a mass, and you will also have to do visual testing because visual testing is done to detect bitemporal hemianopia. All right. What is the treatment? It is the cabergoline that is preferred, please. Very important because it has the ability to shrink the tumor. It restores menstruation and it also restores fertility. Next, we talk about pregnancy planning. If you are planning about planning pregnancy, as the patient to stop cabergoline. I know most of you do not know this, but please do remember cabergoline must not be given in pregnancy. Very important, please. Transsphenoidal surgery can also be done. All right. Next, we talk about macroprolactinoma. Again, it is the cabergoline that needs to be done for the treatment. We talk about acromegaly. Usually, it is because of the increased growth hormone, almost always from a pituitary adenoma. Usually, insulin like growth factor is stimulated by growth hormone. That is why we have decreased glucose in acromegaly as well. All right. Obviously, we know that the symptoms are enlargement of everything, especially the face and the hands. So there can be prominent jaw, there can be wide nose, large tongue, spaced teeth, spade-like hands, skin thickening as well. If there is a pituitary mass, again there will be visual field effects. Bitemporal hemianopia is usually seen. Impaired glucose tolerance is usually seen in acromegaly. There can be increased glucose as well. Sorry, this is increased glucose. Diabetes mellitus, not decreased glucose. One most important thing I want you to understand is for acromegaly. The most common cause of death is cardiovascular death related to hypertension and cardiomyopathy. Please, very important. You will have to concentrate on this. Most of them come back saying that you teach so much, but these are the most important things you will have to remember. Without this, you must not go to the exam. Next, we talk about the diagnosis of acromegaly. How do you diagnose acromegaly? It is the elevated IGF-1 levels which is used for screening. And for confirmation, it is the oral glucose tolerance test that needs to be done, please. All right. What is the confirmation for acromegaly? It is the oral glucose tolerance test. Next, we talk about the management. If you want the management, the first line is please remove the tumor, that is transsphenoidal surgery. Second line is somatostatin analogs, octreotide and lanreotide. Why is it? Because these medications do not have the capacity to shrink the tumor. That is why the first line treatment for acromegaly is transsphenoidal surgery. Next thing, the examiner can ask you about pegvisomant. Very important. Can you see that there is a VIS? Very important, please. VIS is nothing but visual abnormalities or the side effects of pegvisomant. It is a pegylated antagonist of growth hormone. That is why the examiner has made a name to it. It is called MANT. Ant is nothing but pegvisomant, antagonist of growth hormone receptor, please. All right. These are the important things for acromegaly, not very much. Next, we talk about diabetes insipidus. If you are producing more than 3 liters per day, it is diabetes insipidus. There can be two types, central diabetes insipidus and nephrogenic diabetes insipidus. If it is central diabetes insipidus, there is a problem with the ADH secretion from the pituitary because it is present in the central nervous system. That is why it is called as central diabetes insipidus. If the ADH is not working on the kidneys properly, or if the kidneys are resistant to ADH, it is called as nephrogenic diabetes insipidus. Please, very important. Next, we talk about some of the ADH disorders as well. I would like to discuss SIADH here. This is not present in my uh, PowerPoint at this point, but I'll go to SIADH directly. When you talk about diabetes insipidus and SIADH, there will be excessive ADH. What are the reasons that excessive ADH is secreted? It can be stroke, it can be head injury, it can be tumors such as small cell lung cancer, it can be drugs such as chlorpropamide, oxytocin, amitriptyline as well. All right. This inappropriate ADH, what does it causes? It causes secretion of sodium into the urine. That is why urine sodium is high and plasma sodium is low, making it the urine osmolality is high and serum osmolality is reduced. That is what you'll have to remember for SIADH. And one most important thing in my clinical practice as well, if you want that there is SIADH that needs to be diagnosed, I will have to tell you that there must not be any pedal edema in patients who have got SIADH. This is one classic thing you will have to remember for SIADH. If there is pedal edema, it is not SIADH. If there is no pedal edema, yes, it is SIADH. Next, we talk about diabetes insipidus. Whenever there is diabetes insipidus, we already discussed central cause and cranial cause as well. Nephrogenic cause and cranial cause. What are the causes of cranial diabetes insipidus? It is head injury, infections such as meningitis, radiotherapy, or craniopharyngioma can cause central ADH or cranial ADH, whereas kidney resistant ADH or nephrogenic diabetes insipidus secondary to nephrogenic ADH resistance is lithium, chronic kidney disease, renal tubular acidosis. This is what I want you to remember. Diabetes insipidus, there will be serum sodium that is high, urine output is also high, whereas in SIADH, serum sodium is low. Most of the urine is in the Most of the sodium is in the urine. So urine osmolality increases, plasma osmolality decreases in SiADH. Thank you very much. This completes our endocrine, and I'll see you in the next session. Bye bye.